Welcome back, clinical problem solvers, to another Friday edition of VMR with this incredible community. And before we involve Rabih, who's always eating at this time of day, we are going to welcome our case presenter, Umaima. If you don't mind, for those that don't know you, tell us a little bit about yourself, where you are, what you want to do in the future, and what the final diagnosis is.
I'll keep the final DX till the end. Hi, everyone. My name is Umaima Utani. I'm a final year medical student from Morocco, and I aspire to go into IM and maybe nephrology or hemonc in the future. I am a cat mom. I have a cat named Mshisha. She's 1 year old, and she's the sweetest little fur baby. And yeah, I love spending time with my family and friends and watching sunsets in my free time. And maybe I'll tell my breakout room about for the final EX.
Wait, Umaima, what you said the name was Shisha?
No, Mshisha. It's Mshisha in Moroccan Arabic means little cats. So her name is Little Cats.
That's amazing. I don't know. My mind immediately went to hookah, like shisha. I don't know where my mind is, but anyways. Rabih, actually, let's first ask Rabih how he's doing, and then you can take over and start presenting the first aliquot.
Prof. Rez, you're on fire today. I'm thrilled. I'm so excited. Love this this community and group. I've never seen so many people turn on their videos in live, which is really, really nice. And I'm very, very excited for Umaima's case today. And my yogurt. And the final DX. All of it. Take it away, my friend.
Okay, let's go. So we have a chief complaint of general weakness and headache. Do you want me to give more information or stop here?
I have a sneaky suspicion you want us to stop here because I know you know. And I'll say that this is a great point to stop, in large part because you're faced with a tension about how to file the data that's coming away next. And you're very, very tempted because you have a generalized complaint and then you have the word headache. And the headache gives you the sense that, oh, okay, maybe I'll be able to localize the generalized complaint to the area behind the head, either the eye or the brain or the teeth. But the problem with that is that headache offers almost no specificity to generalized weakness. Unfortunately, it is the extension of the generalized nature to involve the head. So this person is not feeling well from head to toe. You may be tempted to question that and say, well, hold on. He says the patient is saying that they are weak. And what does that mean? Unfortunately, weakness here doesn't have discriminatory power to say the patient is neurologically weak, that they may be feeling fatigued or whatnot. So what I'm doing is actively resisting the temptation to pretend like this person has a head problem or a weakness problem, and instead recognize the probability lies more so in saying that this person is not feeling well everywhere from their head to their eyes to maybe their chest or their abdomen, and we'll see where it takes us. So this is a trap to not fall into. It may end up being that this person has West Nile encephalitis, for sure, but the probability of them having a systemic issue is more likely. So I'm really keen to see what data you give us in the HPI that is more localizing than this data so far.
If this patient has West Nile encephalitis, Rabih, I'm gonna come over there and give you a big hug.
Okay, so this is a 37-year-old woman who presented to the ED with 3 days history of fatigue, generalized weakness, and multiple episodes of headaches that prevented her from going to work and just stay in bed with the curtains closed. Do you want me to go more into the PMH or? Okay, so for the past medical history, she had Hodgkin's lymphoma, status post-chemo, but she's been in complete remission for the past 9 years, and she also has dyslipidemia. For the medications, she's taken atorvastatin and some PRN zolpidem. For the family history, her father died because of an MI at age 61, but the family history is otherwise unremarkable. She drinks socially and works as an accountant. She doesn't have any allergies and doesn't have any recent travel history.
Whoever's typing is doing an incredible job of keeping up with you because you are speaking fast. I don't think we need to spend too much time here because not much is added to Robbie's initial discussion. Maybe the one thing that we can add here is the fact that the curtains are closed, which may suggest that she's having photophobia. And photophobia is non-specific, meaning it can result from a myriad of diagnostic possibilities, but it brings to mind something like migraine. In migraine, there's a great mnemonic, and this is a diagnosis you should be very comfortable with because it's such a common cause of headache. It includes the POUND mnemonic, POUND, where it's pulsatile. It's over 3 to 72 hours. It's unilateral. It comes with nausea and it's debilitating. It doesn't really explain weakness, but like Robbie said, weakness is very nondescript and many people can convey they are feeling weak. The next steps is really going to be the physical exam. I took the history of Hodgkin's lymphoma, and all that does for me is to say, how did she first get diagnosed? And can this be a recurrence of Hodgkin's lymphoma? It doesn't really sound that way. Usually with lymphoma, you think B symptoms, sort of a subacute process. But that's something that I'll be tracking, but very hard to relate to the presenting clinical syndrome. So I think really we need more from the physical exam. We don't have a pivot point yet, but the headache is debilitating enough that it's broader here. And a red flag could be the photophobia, and she's quite young. So we'll see what the physical exam shows.
Okay, great. So her temperature is 38.7. I don't know what that is in Fahrenheit. Her heart rate is 126. Her blood pressure is 84/60, and her respiratory rate is 18 and she's statin 98% on room air. She appears uncomfortable. She's a little bit somnolent, but easily arousable. On the cardiovascular exam, she's tachycardic, but doesn't have any murmurs. Her abdomen is soft, but she has mildly diffuse tenderness on the palpation, no hepatosplenomegaly, no rebound or palpable mass. The neuro exam is normal. She's alert and oriented, and she doesn't have any focal deficits. For the extremities, she has one plus one lower extremity edema to the ankle, but she said that this edema has been there for over a year, and she has a 3 centimeters ecchymosis on the right shin. But she doesn't recall any episodes of trauma.
Oh my gosh, this is fascinating. And maybe I can just analyze the vitals, Prof. Rez, and you can layer on the exam, and we can kind of try to synthesize it together if we're left with anything like that. And you just see those vital signs, and you know that you're going to have to engage in management before you have diagnostic clarity. And I think it actually is very, very tricky to figure out immediately what kind of management to do, because you want to first correct that blood pressure. And when you're analyzing the possibilities of that blood pressure, the vast majority of people who have fever, tachycardia, and hypotension have sepsis physiology, and the correction will be achieved with fluids and antibiotics. So that should be your reflex here. And then whether or not you empirically treat this patient is going to be a function of whether you can quickly find a source or whether you treat broadly with broad spectrum antibiotics. So that's the management that you're going to execute immediately. In terms of what fluids to give her, lactated ringers are big, especially with the amount of fluid you'll need to give her to correct her hypotension. It'll be at least 2 or 3 liters, in which case a balanced solution becomes more valuable than normal saline. The only time that normal saline is preferable is when cost is a big variable, when it's convenient and you're only giving a little bit, or pathophysiologically when the patient has an alkalosis that you're trying to correct with the acidosis that comes with normal saline, and that most saliently comes in when the patient has a lot of vomiting. So here I'd be reaching for lactated ringers immediately, and then I would actually pause for a second. Because whenever you're in the situation where you're moving like this, you want to ask yourself, could this patient have a cardiogenic cause of this physiology? And whenever you have a patient with Hodgkin's lymphoma who's gotten chemotherapy, you have to respect the possibility of recurrent malignancy involving the heart. You have to respect the possibility of chemotherapy involving the heart, causing delayed cardiotoxicity, and you have to respect the possibility that many patients with Hodgkin's get radiation treatment. And that may be an incomplete gap in your knowledge whether this patient got it or not. And the radiation effects of the heart range from pericardial to valvular, so on and so forth. But I would then move past that initial concern for cardiogenic component for two reasons. The first is that even in patients with cardiogenic shock, giving them cardiogenic hypotension, giving them fluid, there is a transient response, and there's a tremendous amount of diagnostic information that you can get from their suboptimal response to fluid. And so given the base rate of sepsis and hypovolemia, I would move to that, recognizing cardiogenic and realizing that worsening with fluids might bring about cardiogenic, and that's not necessarily bad in a monitored situation. But if we go back to beyond just the base rate, this is what we talked about yesterday. Hypotension in the context of cardiogenic or obstructive disease almost always carries with it a story that's revolving around the chest. In PEs and heart failure, there almost always will be chest pain, shortness of breath, and the patient will point you in this direction, and she is not. She hasn't had any chest pain, she doesn't have any tachypnea, she doesn't have any hypoxemia. So I would probably, just with this data alone, give her fluids and have a very low threshold to initiate empiric antibiotic therapy for her. All right, Prof. Rez, pass you the mic.
Rabih, I don't want you to stop speaking. It's like you're such a great teacher and storyteller. Had me captivated. And I think something I've learned, and this was in medical school, like anyone who's hypotensive, regardless of the etiology, just give fluid. And when you go to the bedside, a really great maneuver you can do is elevate the legs, literally hold it perpendicular. I don't know, do you do this in the ED, Rabih? Like I did it just a month ago. The way I do, I just literally go in there because you have about 500 cc's there in the lower legs because of gravity. And so it's like the quickest way you can give a bolus and see if the patient is fluid responsive for the eventual intravenous fluid. Is that part of your practice, Rabih, when you have hypotensive patients in the ED?
My practice is simple. If Prof. Rez does it, I probably should do it too. But yes.
I always like to pick Rabih's brain because he is an emergency medicine provider. This is such an interesting exam. And what do I mean by that? I'm pausing for increased effect of the teaching point we're about to make. But look at the right shin. There is an ecchymosis. Ecchymosis is a spectrum of bruising. You start at petechiae, which are very small, pinpoint erythematous lesions. You go to purpura, which you have a little larger, and then ecchymosis. So this is ecchymosis just purely based on the size. And what it tells us is that the red blood cells have extravasated from the vessel. Now, there's a couple possibilities here. One is that she has local trauma to that area, that she just doesn't recall. This poor lady is hypotensive. Forget the headache, forget the weakness. 37 years old with this blood pressure, it's really worrisome. So she may not communicate that, hey, yesterday I was walking and my leg inadvertently hit something, and that's why I have a little bruise. But you have to pause for a second from a diagnostic perspective. Management-wise, you're not going to pause. You're going to be going full force forward. But from a diagnostic perspective, you have to ask the question, is this really local, or is there a systemic issue that led to the bruising or the extravasation of red blood cells? Then you say, well, if there's a systemic issue and you see the blood pressure being that low, could she be hypovolemic, not because of decreased PO intake, but potentially from blood loss that has yet to be conveyed to the providers? So all of a sudden, I'm wondering, is she having an internal hemorrhage or not? And that bruise is the clue to internal disaster. So let's entertain the possibility that this is not just trauma related and it's atraumatic bruising. When you do that, it comes down to one of two issues. Either there's a problem with the vessel, or there's an issue with clotting and the coagulation cascade. For primary hemostasis, you have platelets that are involved. For secondary, you have clotting factors. So immediately I want to know the platelet count. And I want to know what the PT and PTT are. This doesn't really sound like a vasculopathy or vasculitis because it's so local. And it could just be trauma and it's unrelated. But given that she's hypotensive, you have to entertain the possibility of some form of bleeding. So PT, PTT, platelet count. Then you look at this edema. That's odd. 37 with lower extremity edema. And of course, we're going to prioritize causes of unilateral edema, but you have to be very cautious, folks, because of how the circulation in the vessels cross in the lower extremities. Any cause of bilateral edema will be a little worse on the left side. So you have to be open to the possibility that she actually has bilateral lower extremity edema, but the left side is worse than the right side. For unilateral edema, the main thing is there a clot or is there some kind of obstruction going along Rabih's thoughts that maybe a lymph node is enlarged, something is in the groin and it's obstructing venous return, causing lower extremity edema, or she has a blood clot. If she has the clot and she's bleeding, we won't entertain that possibility, but that could be where we're heading in this case. And then is it bilateral? Is it really that she does have obstructive cardiomyopathy and now she's having bilateral lower extremity edema? But the fever really prioritizes a distributive cause of shock, specifically something that could be infectious in etiology. The diffuse tenderness on deep palpation makes you wonder, is there like an organ that's damaged? Are you having bleeding internally? Or is there an enlarged organ that we'll only detect when we get a CT scan? Of course, all of this we're doing in slow motion. In real time, you're going to get those basic labs and you're going to get a CAT scan as soon as possible to look in the peritoneum. It's going to be critical to get that CAT scan. Rabih, any other thoughts? Because I think it's such a rich exam that maybe your thoughts may have gone somewhere else. Or
No, I was spot on with you, Prof. Rez. I'm taking a mental shortcut, and I would be in real life, is because I think if you say fever and ecchymoses, like the mental shortcut would be fever and DIC. And I'm trying to think like what organisms have a propensity to cause DIC. And so running through that list and helping me choose my empiric antibiotics. So now that you've like essentially helped us think through what the sources could be, I'll just clarify that what I would probably do for this patient is almost certainly vancomycin. And the reason for that is the rate of DIC with strep and staph is very, very high. And then I would definitely do gram-negative coverage because a Haemophilus influenza, especially if she's not been vaccinated, type B can cause a rapidly progressive DIC, as can Neisseria meningitidis. So for those two things, for those two organisms, ceftriaxone would be a good catch. And then finally, you want to do a good exposure history. So is she exposed to dogs? Is she exposed to mosquitoes, ticks? Because organisms from those vectors, Capnocytophage, Babesia, can be rapidly fatal. So I think in this person, vanc ceftriaxone until you get a little bit more clarity.
I absolutely love that. You almost are saying, is this purpura of a severe? I love that idea, and like alterations in the clotting factors.
I love the discussion so far. Okay, so concerning the labs, her white blood count is 2, her hemoglobin is 6 with an MCV of 74, and her platelets are 21. The absolute neutrophilic count is 0.9, and on the peripheral blood smear, there was 1 rouleau and +1 schistocytes. For the chemistry, the sodium is 131, the potassium is 4, CO2, BUN, creatinine, and glucose are all within normal limits, and her AST was 54, ALT of 110, and the Billy, alk-phos, and albumin were within normal limits. For the coax, the PTT was 38, PT 15, and INR of 1.7.
Wow.
What do you think? Should we do breakout rooms? The good time.
Oh yeah, that sounds
Yeah, you
great.
think so? I think we've gotten to like the heat of the case. Fair? Okay, all right, y'all. We'll get you back to your groups and And hopefully you have a wonderful conversation. We'll have it like 5 minutes or so.
All right, YouTube audience, I guess we're gonna keep discussing is what I've been told. For me, Rabih, I think that we are dealing with pancytopenia
Yeah.
and DIC. And when it comes to the pancytopenia, once you have multiple cell lines down like this, and you have a young patient where you're not necessarily concerned for nutritional deficiency or a toxin exposure, at least based on history, I think the primary worry is some kind of marrow pathology. The schistocytes, I think, would be in line with DIC. And with this pancytopenia, honestly, reflexively, I'm like, what type of a leukemia is associated with DIC and bleeding? And what comes to mind is acute promyelocytic leukemia. So I'm very concerned that this patient has an underlying leukemic process. So for her, in addition to the antibiotics, because by definition, she could have a superimposed infection. You could have infection that causes inflammation, marrow suppression, pancytopenia, and DIC. So I think those are the two thoughts. Are you dealing with a leukemia that causes DIC, or are you dealing with an infectious process that causes DIC? And for it's just that the cell counts are so striking. And I've just never seen that, with your run-of-the-mill bacteremia. So that's why I'm prioritizing a leukemic process, keep the antibiotics on board, really look at that peripheral blood smear for our rods, as you can give a life-saving intervention with ATRA. But also I'm calling the hematologist oncologist for an earlier bone marrow biopsy, but would love to know your thoughts. Maybe I'm getting trapped in my S1 thinking here.
No, I'm right there with you. It's like, I think that at the end of the day, when you see those cytopenias, you're like, what kinds of infections can cause acute cytopenia? Because the differential diagnosis of cytopenias with infection is so long. You can have any infection that triggers HLH that causes cytopenias. You can have granulomatous disease to the bone marrow. But I think presuming that she would have had symptoms if they were subacute, like a hemoglobin of 6 pestering along. So I think I'm inclined to think that they're acute in large part because the ecchymosis is new. Then she's just so sick. So acute cytopenias plus infection, for me, the only match there is tick-borne diseases. And she doesn't really have the signature of that with liver enzyme elevation and with any exposures that we know of. So I think what I might do, this is just like the Denver cases, might think about doxy, but then really know in my heart of hearts, like, gosh, I worry that she has a crazy leukemia, in large part because she has a risk for it. She's got Hodgkin and she's got chemo. So secondary leukemias as a result of chemotherapy would worry me. And when you see like leukemia plus DIC, I think APML is a big, big, big worry. And it's a worry now because we heard she had headaches, and the risk of spontaneous intracranial hemorrhage with APML is terrifying. So yeah, I think it's like review the smear, see if there are blasts in the smear because the automated smear may have missed them, and get on HEMONC on board real quick. Oh, well, ma'am, you raised your hand. Go ahead, please.
Yeah, I just have a question for both of you, for the YouTube audience. Would you still keep leukemia in your DDX even though there are no blasts in the peripheral blood smear?
Epic question. Prof. Rez, go for it.
Yes, because there is an entity called aleukemic leukemia, meaning that you might not see, for one reason Rabih mentioned, you may just not see it in the automated reader and you need to look at the peripheral blood smear, but maybe all the blasts are in the marrow and haven't yet left the marrow. I don't know, Rabih, the percentage of cases that might manifest like this. It's probably less common for sure. I just don't know what percentage.
Yeah, I don't know either, Prof. Rez. For some reason, I have like 10-15% in my mind, but
yes,
I'll look at the number in Evernote. But I just say like that's that you kind of in especially in APML, patients don't tend to have they tend to present with pancytopenia because their bone marrow is so sticky and so crowded with blasts. So in many ways, I think you expect to have if leukemia is presenting with I'll just say this. I think if you're detecting leukemia as part of a leukocytosis, like so many cells, I think I would be surprised if not even a small amount of those are blasts. But if with leukemia presenting as cytopenias, I think you have to recognize in that context the aleukemic version, and especially respect APML, because most cases of APML present with depressed cell lines because of the stickiness of the APML cells in the bone marrow. Yeah, really good question. Prof. Rez, reading between the lines, I think that Omaima is being very nice to us. So I hope we're on the right track. I guess one thing, Prof. Rez, that I'm wondering that I haven't come across before is how the idea of anticoagulation for DIC. Is that something you've come across or thought about? Like, do these patients get heparin? Do they not get heparin? Like, how do you think about that?
Oh my gosh, such a phenomenal question. Because we know with like DIC, you're having these microthrombi in the vessel, but you're also vulnerable to bleeding. So these patients can manifest with both bleeding and clotting. And I think my general experience in like reading the literature, bleeding is usually more common than actual like effects of thrombosis. But in this type of patient, I think treating the driving process, like, is it DIC due to cancer? Is it due to infection? Is it due to, trauma, pregnancy? Treating the underlying process as a way to treat. But yeah, someone like this with like the thrombocytopenia, the ecchymosis, and without an obvious like significant clot, I wouldn't anticoagulate. What about yourself in your practice? What do you do, Rabih?
I don't know, man. I don't know what people do these days. I have to read about it, to be honest. Because it's so tough to manage these conditions where the patient can bleed, but they can have a devastating thrombosis. I feel like if anybody were to give a patient anticoagulant, in this case, it would certainly have to be heparin, because you want something rapidly reversible. But I'm going to read about that after this, because I don't think I know or have a good grasp of how people manage this situation. Yeah.
Hey, we don't do management reasoning, my friend. Let someone else read about it.
Amazing. All right, sure. I'll let people back in, and it takes about a minute, Omaima, for the breakout rooms to close. So when you start to see people come back, feel free to take us away to the next round of data. I have a feeling people are gonna slowly trickle back, because there's no way they finish their conversation.
Yeah. Do you want me to start now or wait for a few seconds?
Why don't we wait? There's like 40 seconds left, so people who are here can.
Yeah, and just like to answer your questions, during my leukemia rotation, I feel like most doctors, if they have to choose between bleeding and thrombosis, they would much rather err on the side of thrombosis than bleeding, because it's like mostly associated with higher mortality than thrombosis. So they would prioritize giving patients cryo or reversing the DIC and then taking care of the thrombosis later.
That makes so much sense.
Thank you for that clarification, Omaima. All right, it was like 7 seconds, and then you can keep us going. All right, y'all, welcome back. Hope you had a great discussion. Prof. Rez and I chatted it out, and Omaima will give us some more data.
You may have had a great discussion. We had a better one.
All right, I think everybody's back. Omaima, take it away, please.
I'll give you some imaging before going back to the labs. Her bedside chest X-ray was normal. Her EKG was normal, except for the tachycardia. And we ordered a CT head because of the headache, and it was negative. We then ordered an LDH. It was 400. Haptoglobin was 100, and the parasitic smear was negative.
Oh, so, our working hypothesis, just to summarize for everybody, was we were summarizing this patient as a 35-year-old woman with a history of Hodgkin's on chemo, who is here with fever, cytopenias, tachycardia, and hypotension. And our working DDX was that she, to be concerned about a bone marrow process of leukemia, plus minus a superimposed infection. And the only infection really that can do this prominently are tick-borne diseases. And we were talking about how if this were leukemia, it would be aleukemic leukemia, where there are no leukemic cells in the blood, but mostly be located in the bone marrow. And I think what the next step of data helps us, Prof. Rez, is really to reduce the probability of a prominent systemic destructive cause, because the haptoglobin is normal. So invoking a peripheral cause is a little bit weakened by this data point. So I think I'm really glad this patient isn't spontaneously bleeding into her head. I'm now, if you're tipping the scale between peripheral destruction versus production issues, the fact that the red blood cells don't appear to be destroyed as inferred by the normal haptoglobin, it pushes us a little bit more, even more towards the bone marrow. And so I think that would be a really, really important step in this patient. But curious what your thoughts are, where you stand.
I stand underneath your feet, my friend. Nothing to add. I don't know.
Wait, am I stomping on you? Is that what's happening? Under my feet?
It sounds better in Farsi.
Okay, all right. How do you say it in Farsi? You should say it. Let's hear some Farsi poetry.
You just caught my bluff. Actually, it's not. There is no saying in Farsi. I just realized it didn't make much sense. That's like my go-to when I say stuff that doesn't make sense.
We got to play poker someday, Prof. Rez. I think I'll get rich off you this time. All right, tell us more.
Yeah, someone was asking about the reticulocyte. Sorry, I forgot that. It's 3%. The ferritin levels were normal. And we ordered the tenderness on her abdomen got a little bit worse on the next physical exam, and we ordered a CT abdomen that was normal. Her HIV, CMV, serologies, adenovirus, like we ordered a lot of viral serologies, and they all came back negative. I have 2 more aliquots until the final EX. Do you want me to give you one more piece of data? Okay, the serologies for Borrelia and Ehrlichiosis were negative. And we gave her like 4 liters of normal saline. We didn't give her lactated Rangers because there was some, we were worried there was some tumor lysis syndrome underlying it, and the lactated Rangers has higher concentration of potassium. So we opted for sodium, but the hypertension persisted and it was still at 80 in the 80s, 60s.
Thank you so much. And, something that Rabih and I discussed during the breakout session was like a pattern emerged here that activated S1 thinking because we know this specific diagnosis. And that is when you have extreme pancytopenia and DIC, you really have to think about leukemia, specifically APML, which has this tendency to cause DIC and pancytopenia. So that's a pattern that Rabih and I have learned over the years. So that's a true concern for us. And I think reviewing that peripheral SMO very closely for any kind of hour rods or anything that puts you in that acute promyelocytic leukemia bucket, having a very low threshold to do a bone marrow biopsy, because if that ends up being the diagnosis, this is the one time where you can reverse the process with ATRA. And it can be life-saving. So if this patient came in at 2 a.m, you better believe I'm talking to a hematologist, and hopefully all of you have access to hematologists. If you didn't, this is someone I would empirically treat. Like when I was in Saipan practicing medicine and I didn't have access to any of the subspecialists, you have to take that leap, because if you miss it, it can lead to death. Then we paused for a second and said, could it be an infection? Usually infections that causes pancytopenia, as Rabih mentioned, is in that tick-borne non-Lyme category, because Lyme has a normal CBC. But then we looked at the liver chemistry tests, and they're not abnormal, and usually those are abnormal. So if this was a tick-borne, it would have to be a severe form. I think Rabih made the point of just starting doxy, which makes a lot of sense, so we don't miss that. So our final diagnosis, Umaima, in the order is APL and DIC, then some kind of tick-borne infection, we think that's less likely. For this, we're thinking Atra and doxycycline as our empiric therapy. And that LDH being elevated too, that just is telling me that there's some increase in cell turnover, which would again favor a leukemic process over an infectious process. Rabih, anything to add before we get our answer?
Nada. I think that's superb.
Okay, great. So cytogenetics on the peripheral blood were ordered, but they take some time to get to come back. And in the meantime, her anaplasmosis serologies came back positive. Her primary hematologist chose for her not to undergo bone marrow because the results will not be very accurate because of the infection. And she was started on doxy way before the anaplasmosis came back. And because her CBC took a lot of time to go back to normal, so there was some doubts. There could be some underlying leukemia or myeloproliferative neoplasm that we did not see, and we're just probably anchoring on the anaplasmosis. So bone marrow biopsy was ordered 4 weeks later, and it came back normal.
Absolutely amazing and very, very humbling. And I think what you should pay attention to is I'll just summarize the key journeys through this case and ask Prof. Rez to reflect on his, which is the first is generalized weakness and headache are not specific. You saw that. But what happened was we learned that this patient is a vulnerable host with cancer in the background. And then you saw a pattern, fever, cytopenias, and DIC. And I think that pattern is basically tick-borne disease versus leukemia. That really is what it comes down to. And I think as you wait for diagnostic testing to return, doxy becomes a very, very important therapeutic intervention. And what Umaima just taught us at the end, which is that who is more likely to get bad anaplasmosis, a normal host or a person who has just caught leukemia? And you saw that reasoning being taken to the next level by watching this patient and making sure that she wasn't an immunocompromised host who happened to have a tick-borne infection. Do you guys know how many of these infections are asymptomatic? There's anaplasmosis, Lyme disease, the majority of them are asymptomatic, so much so that they are one of the most common forms of bacterial transfusion-related infections. Think about that for a second. You go to give your blood and you're supposed to be perfectly healthy, and they check to make sure you are, and you can still transmit anaplasmosis through that mechanism. So you have to be very, very careful. And just because a patient has anaplasmosis does not prove that this patient is symptomatic from anaplasmosis. So there's a lot of layers of nuance here, including ensuring that the most morbid possibility, an underlying cancer, is definitively excluded. So there's a lot of nuances in this case, and I really appreciate you, Umaima, for bringing it through. But at the end of the day, a very classic presentation of a notorious and humbling tick-borne disease. Prof. Rez?
Yeah, I also learned that
sorry.
we don't have like to see the tick for it to be a tick-borne illness. It was my first time seeing the tick-borne illness disease because we don't have them in Morocco. So yeah, it was a very educational case for me as well. And yeah, fluids and doxy were started shortly after the patient was admitted.
Yes, I'm going to pass the mic to Noah. And I love this case. I really did. And what a great place to be humbled. But I really don't think that the reasoning was faulty at all. I think you had to be concerned for acute leukemia for sure. And you had to be concerned for tick-borne infection. And yeah, so I really love that. And I think those were the two main buckets to consider. An empiric treatment is definitely warranted in such a case. And I can't wait to dive into the nuances, Rabih, of like, despite them diagnosing the patient with anaplasma, and these are serology, which always, whenever I see serology being positive, always makes me question any diagnosis as opposed to actually seeing the parasite. But yeah, I think it's a very good case. And even the hour rods not being there, you have to understand that these stuff, one, depends on the sensitivity of the test, and also the person who's actually reading the peripheral smear. So it can't be completely excluded. So Robbie, all I take away from this, man, is that low threshold to initiate a treatment that has very low side effects, but can be potentially life-saving. It's almost like the bite-sized teaching that has significant impact. This is similar to that, but I really wonder if there's any other diagnoses we should have considered, or it really was these two, but that will come up later in reflection. As opposed to me rambling on, I want to pass the mic to Noah to teach us even more.
Hey everyone, my name is Noah. So this case opened up with very unspecific symptoms, weakness and headache. We talked about how Rabih did not get baited into prematurely localizing the symptoms, so we kept our differential very open. We also briefly talked about the photophobia, which brings to our mind migraines. We have a very nice mnemonic, which is a pound mnemonic for migraine. So it's pulsatile, 4 to 72 hours, unilateral, has nausea or vomiting associated, and it's disabling. After we had a bit more of the history and the initial physical exam with the labs, we saw a clinical picture of hypertension, tachycardia, and fever. So this immediately brings to our mind sepsis physiology. And we have to start managing this patient as well as diagnosing him or her in this case. So with LR, fluids, and antibiotics. At the same time, we're running through differential diagnosis in our mind. And because of the history of Hodgkin's lymphoma, we also thought of cardiogenic shock, maybe from a relapse of the malignancy or from radiation. The history, which wasn't focused on the chest, was more generalized symptoms, and the base rates of sepsis pointed us towards the first hypothesis, so sepsis physiology. And we have a nice pearl for a fluid responsiveness test, which is elevate the legs of the patient and follow the blood pressure to see if it improves. Going further in the physical exam, we saw red blood cells out of the vessels. Then we invoked the petechial rash schema, which is vessels versus hemostasis. Vessels can be inflamed or have another problem. This history and presentation wasn't very suggestive of that. We were thinking more of hemostasis, either problem with platelets or with the coagulation cascade, which was confirmed by the labs. We then talked briefly about edema, which, if it is unilateral, can be a clot versus other obstruction, or bilateral. This patient had only left leg edema, but bilateral edema is still possible because of the anatomy of the veins, and the edema on the left leg will be bigger than the right one. And we said that the bilateral edema can be a reflection of the systemic process. Now, piecing it all back together, we have a patient that presented with fever and echinosis, and the system one thinking is DIC. So we immediately started asking ourselves which organisms are associated. What do I have to cover in this patient? What can I miss? And gather more history about the exposure. Once we got the labs back, we saw pancytopenia. Pancytopenia has an amazing schema in the website. It can be either infiltration by malignant or non-malignant causes, bone marrow failure, or peripheral destruction processes. In my breakout room, we focused more on the peripheral process, but the history in the labs pointed us towards a malignant infiltration, the APML. Also, the labs suggested the DIC picture. So once we got it all back together, pancytopenia and DIC, again, system one thinking, APML versus tick-borne diseases, which were less likely given the labs. Here, I want to take a pause and talk more about how I found the discussion beautiful, because we thought of the worst case scenario. We imagined that this patient had APML, and if we didn't give Atra to this patient, she would probably die. So we hedged our bets and we started Atra and doxycycline. And further labs confirmed the second suspicion, the less likely one. But if this patient had APML, we would have saved her. And for the final teaching point, anaplasmosis may not be symptomatic. That's why we have to make sure that the patient does not have any other systemic process that's causing her to have all those symptoms. And that's all I have for today.
I think Omaima's going to break her computer with a smile, and Prof. Rez is going to clap his way to the computer screen. That was absolutely amazing, Noah. Thank you so much. Absolutely superb. Prof. Rez, I don't know if you heard this, but Noah's going to start a TikTok channel of teaching points by riding his bike and doing teaching. I'm kidding. I just keep nudging him. I really think he should.
I was gonna say, can I be on that channel and do a little dance and teaching?
Amazing. Well, thank you all. Thank you all for hanging out. I hope you enjoyed your breakout room and getting to know each other. And I was going to say that tomorrow at 9 a.m. Pacific at 12 p.m. Eastern, we have a very, very special session, again, led by Yusuf and the management reasoning team. So very, very excited. Hope you can join us in real time and actively think through with everyone here in the breakout rooms how to not only diagnose a patient, but to actively manage them at every step. And Omaima, thank you again. Absolutely superb case. And Prof. Rez, you're free to step on me now anytime of day. Bye.